Thank you, everyone, for joining us. I think a few more people might trickle in, but this is our weekly Center for Healthcare Policy and Research seminar series. Some of you are joining us as part of a graduate seminar in public health. Some of you are doing continuing medical education credit, and some are just really interested in the topic or the topics of our seminar series. So for those of you who know, we really rotate around on topics at this seminar series, really thinking about applied clinical research, policy research, community engaged research, and beyond. And today we have a really great speaker with us who can sort of, I think, speak to multiple of those missions of the center. So we are so fortunate to have Dr. Elysia Alvarez today with us. Dr. Alvarez is an associate professor. She's a practicing pediatric hematologist oncologist here at the UC Davis Comprehensive Cancer Center. Also an esteemed researcher and working on some global health research as well as domestic research for adolescents and young adults with cancer. She is trained both at Irvine and at Harvard, and we're just so thrilled to have you here to share a little bit about us with some of your recent work. Thank you for joining us.
Hi, thank you so much for having me and asking me to give a talk today. Feel free to interrupt me at any point. We can keep these casual, nice questions only. Just kidding. Feel free to challenge me as well. And I like to present at these things because I'm always open to collaboration, especially outside the field of oncology as well. I think things move forward faster and better in a collaborative way when we reach beyond our silos. So always open to hearing from people outside my field. So I have nothing to disclose. I'm going to talk to you today about adolescents and young adults with cancer. This is a topic that is near and dear to my heart and something I'm very passionate about and what my entire research portfolio focuses on. And I am going to go into some of the specifics of that. But first, my overall research kind of umbrella goal is that I want patients, adolescents, young adults with cancer, to get the most appropriate treatment for them, regardless of where they live in the world. And while we obviously live here in the United States, in a high-income country, greater than 80% of adolescents and young adults in the world live in low middle-income countries. So there's a huge population out there in resource-limited settings, which we could argue we have as well in the United States, but also in other parts of the world that we need to think about. And so, given this term is getting used more broadly now in different disciplines, but was first, I think, coined in oncology. So adolescents, young adults, or I'll refer to them as AYAs with cancer. So why focus on them? How do we improve care for these patients? I'll be talking about access to specialized care and access to guideline care or best practices. What are the global implications of this work? So touching upon my global work and then possible next steps. So why AYA patients with cancer? So this has now been, I used to say a couple decades ago, but now this was at the late 1990s, early 2000s. This group was defined by the NCI as ages 15 to 39. So you can see that this is quite a large age range. But there are approximately 90,000 AYA patients diagnosed with cancer each year, and you can see that cancer gets more and more common as people get older. So as a pediatric oncologist, this group is much larger than the younger patients that I treat. And so why should we think about them differently? So this is from our Lancet Oncology paper from 2022, and this is the global burden of adolescent and adult cancer. And here is a figure where on the bottom you have your leukemias in red, in the top above the gray. I don't know if people can see my cursor, but above the gray, you have mostly your carcinomas, and then the gray in here is other malignant neoplasms, which we're working on better defining. But you can see that there's this transition from the leukemias and the blastomas, more to the carcinomas as you get older in the age range. And there are more distinct cancers within this age group when we think more about Hodgkin's lymphoma, germ cell tumors that are more common in this age group, and including sarcomas like Ewing sarcoma and osteosarcoma. And so survival overall has improved less in AYAs compared to younger and older patients for multiple cancers. This survival gap is improving over time, but still exists for sarcomas and leukemias. There's a lot of contributors to why we think this survival difference occurs. People have thought about low clinical trial enrollment, pharmacokinetics, different tolerance to therapy, psychosocial factors. If any of you know a teenager, you know sometimes it's hard to get them the care that they need, but there's also a lot of insurance issues that transition from being a child under your family's care, guardian care, to being an adult, young adult on your own. Disease biology showing you that there's different cancers in these groups, and then health services, which is where I focus my research. So when I was a fellow a while ago now, there was a progress review group that met for the next steps in adolescent and young adult oncology by the NCI, and the NCI is what first defined this age group as being separate from pediatrics and adults. And one of the things they said that needed to be determined is to identify where AYA patients with cancer are treated. People really didn't have a good grasp of that, so that's one of the first things our group did. And so we found that the majority of patients, this was inpatient hospitalist discharges, the majority of AYAs were not seen at a specialized cancer center, which we define as a National Cancer Institute cancer center or a Children's Oncology Group center, of which UC Davis is both, has both of those designations. And so we found that for the younger patients, ages 15 to 18, the majority received all their care at a specialized cancer center, whereas the majority of older patients received none of their care at a cancer center. And we also saw that when looking at uninsured patients, the majority received none of their care at a specialized cancer center. And so we also wanted to look at what factors were associated with specialized care at a cancer center. And we found that if you had public insurance or were uninsured at diagnosis, you were less likely to be seen at a cancer center. And if you were a Hispanic race ethnicity, we found that you were more likely if you were a younger age and if you lived in a neighborhood that was at least 2 times the federal poverty level. And so we found that there's a distinct population not being seen at specialized cancer centers. We identified barriers with decreased utilization. We felt this was an important first step to define the problem. And I realized while it was important to describe, we needed to figure out if there were any subgroups that benefited more from care at a specialized cancer center. And so when we think about this, like putting on my public health hat more at a health systems level, it may not be reasonable for all AYA patients with cancer to go to a specialized cancer center. So we see that this group is not nearly as big as the adult oncology group, but it's definitely bigger than the pediatric group, where in pediatric patients, it is the expectation that they will all go to a children's oncology group designated center, but there's not really that mandate for this older age group. And if we think about all the hospitals in California, only 6% are specialized cancer centers. So can we really expect that all patients go there? And so how can we improve care for this unique patient population is the question I'm always asking. And so if I think about things at a systems level, we looked at access to specialized cancer centers. And then at a hospital provider level, we're looking at access to guideline care or best practice care. And then at a patient level, I'm looking at delivery of guideline care. So how can we get that to the individual level? And this is what I'm focusing my KO8 on that I will touch upon later. So how do we improve access to specialized care? If not all patients can be seen at a specialized cancer center and a lot are seen at a community hospital within this age group, what can we do? And so our group looked to see, does this even matter? And so we've looked at leukemia, we've looked at soft tissue sarcoma, we looked at Ewing sarcoma, osteosarcoma, more recently germ cell tumors. And so here to just show you a little bit of what that looks like, here is a Kaplan-Meier curve for people. I think most people are probably familiar with this, but this is a survival curve over time. And you can see the top 2 rows here are children and the top bottom rows are AYAs. And the dark blue is patients who received all their care at a specialized cancer center. And the light blue are patients who received part none. And you can see that there is a difference in survival with care being with all care being at a cancer center having improved survival. And this also held up when we adjusted for known prognostic factors and treatment and type of leukemia and year of diagnosis and comorbidity and complications. We found that there was a survival benefit to being seen at a cancer center. We also found this for Ewing sarcoma. Blue is patients who received all of their care at a cancer center. Red is patients who received part none. This also held up even more dramatically when looking for known prognostic factors. And this even happens because you could make the argument that it has more to do with their disease stage as to whether or not they survive. And while that is true, this top line is all patients who received care at a cancer center. This purple line is patients who received part none and with non-metastatic disease, meaning disease is only in one location. And then when we look at the bottom two lines, this represents metastatic disease, so disease in more than one location, and there still is a survival advantage. And so we found a difference in survival by age and stage, better survival associated with patients receiving all care at a specialized cancer center, even controlling for known prognostic factors such as metastatic disease, tumor size. And so all this work with our work, along with work out of the City of Hope and our colleagues at Stanford, went into this bill, the California Senate Bill 987, which is the California Cancer Equity Act, which mandates that patients with certain rare types of cancers at least have a consultation at a specialized cancer center. So I think this is a huge step forward in getting patients the care that they need. And so again, if we think about this and looking just at the sheer volume of patients, how few cancer centers there are. So if every AYA may not be able to go to a specialized cancer center, we need to think about why is survival improved at a specialized cancer center. It's a little bit hard to determine all of that with the data that we have, but one of the things we've thought about is, could this be due to delivery of guideline concordant care or best practice care? Are you more likely to get this care at a specialized cancer center? And does this care impact survival? And so can we improve delivery of guideline concordant care? And so one of the other things that came out of this progress review group was to determine components and receipt of optimal cancer-directed therapy by age and cancer site. And so our group has worked on this for several cancers, for germ cell tumors, for osteosarcoma. We're looking at soft tissue sarcoma. That analysis is complete. And then we're also completing analysis looking at Ewing sarcoma and colon cancer. So we found that less than 50% of patients with osteosarcoma receive guideline concordant treatment. And we found that there is a significant association with worse survival if you don't receive guideline concordant care. And this was also shown in our survival curve, with blue being guideline concordant care and red being no guideline concordant care. And then we found that if you were seen at a specialized cancer center, you were more likely to receive guideline concordant care. And also if you were treated by a pediatric hematologist oncologist. Not to get into the nitty gritty of chemotherapy, but there is a certain drug that is considered guideline care that we always give in pediatric hemonc. I would say 99% of the time, unless there's a real indication not to. And a lot of adult hematologist oncologists don't, because they're worried that patients can't tolerate it. So there are other factors that go into this, but I thought this was interesting finding overall. And so how do we improve uptake of the delivery of guideline concordant care? So the data I showed you is actually the background data that I used for applying for my K08, and I just am starting my second year of that from the NCI. And so I decided to focus my K on learning about implementation science. So how can we take the best practices that we know and improve uptake of these, given that we've seen in California about 50% of patients don't receive the care that we currently know to work and potentially improve survival. And so this is called Barriers and Facilitators for Delivery of Guideline Concordant Care for Adolescents and Young Adults with Sarcoma. And so while I don't have a lot of data to present to this, I just thought I would show it to this group. And again, at the end, welcome any questions, feedbacks, idea for collaboration. I am very new to implementation science, but I'm lucky to have wonderful mentors. So the first aim is to identify barriers and facilitators to delivery of guideline concordant care for AY patients with sarcoma. And so to do this, a first aim, we are trying to look at these barriers and facilitators using CFIR and have been doing these through interviews. And so we've conducted 20 interviews so far, 19 providers, the majority are pediatric oncologists. So our next phase has really focused on talking with medical oncologists to really get at why you're more likely to get guideline care if you're treated by a pediatric oncologist versus an adult oncologist. So I'm happy to say we actually have 5 interviews lined up with adult oncologists. And we have piloted with one patient. We're piloting with a caregiver, and then we'll broaden it to more patients and caregivers from then, just from the patient perspective, because you can imagine this age group has a lot of um, working, starting a family, it's school, and there's just a lot of competing priorities. And so finding out from them too, what are these barriers and what are ways that we can improve getting the care they need to them. And so a lot of the barriers that have been identified, keep in mind these are from clinicians, are comorbidities, lack of a defined clinical space, lack of communication between patients and providers to providers. One nurse said they're in a gray zone where they technically could be seen on our pediatric floor, but seen on the adult floor. There's no perfect place for them. A pediatric oncologist said a 24-year-old with Ewing's should really be taken care of by pediatrics, but sometimes it's a battle, especially if they don't have good insurance. And then non-clinical or competing demands for treatment, parenting young children, financial strain, lack of mental health support. One nurse said they are in this weird middle ground, too old for child life, too young for adult mental health. Insurance and access make it worse. Our bone cancer patients face so many emotional issues, amputations, disfigurement, loss of fertility. The treatment is brutal, and that's from an AYA social worker. And so you can see there's a lot of challenges in delivering this care. It's not so black and white as most research is not, and more nuanced as we think about how we can improve delivery to these patients. And so the second aim is to systematically develop a tailored implementation blueprint for delivery of guideline concordant care for AYA patients with these sarcomas. And so in doing this is the next step that I will be embarking on. But we want to identify outcomes and performance objectives, create implementation strategies, produce a protocol and evaluation of implementation outcomes. And we'll be doing this with a stakeholder advisory group that will be made up of different types of providers, patients, and caregivers. And then our third aim is to evaluate the feasibility and acceptability of a cancer care delivery implementation blueprint to improve delivery of guideline concordant care in a pilot trial. And so with this is everything together, we will be using REAIM to look at potential outcomes. We will develop an implementation blueprint or protocol, and then we will pilot this. Our goal is to pilot this in 3 local sites to see if we can, with these strategies that we identify from the interviews and also from our stakeholder group, if we can increase delivery of guideline concordant care. And so for future work, I'm focusing, like I said, on recruitment of medical oncologists, which we are working on, recruit patients from both pediatric and medical oncology settings, and recruit for our stakeholder group of 10 to 12 participants. We already have people that have agreed to be part of this group, so I'm just working on getting more. And then evaluation of guideline concordant care in AYAs with Ewing sarcoma, which we are currently completing, and then colon cancer, which is out of my wheelhouse as I don't provide care clinically for these patients, but this I'm sure you've seen in the news and everything is a growing concern among AYA patients. So partnering with medical oncologists in GI oncology on this endeavor. And so, what are the global implications of this work? So, I really enjoy the work that I do here. I really enjoy the groups that I've worked with. I was so fortunate to have my mentor, Teresa Keegan, bring me to UC Davis to meet everybody here and then to be able to work here and continue to work with this group. And I'm also so fortunate to be able to work with the AY population on a more global scale, and wanted to talk to you about that work today too. So we've talked about how many AYs there are within the United States with cancer, but there are over 1.2 million AYs diagnosed with cancer each year globally. And this number is expected to continue to rise. And as I said before, over 80% live in low and middle income countries. And we found from our 2019 data that we're currently updating to 2023 that it was the fourth leading cause of death globally. And this was the first time that AY cancer had been looked at compared to other diseases. And I think a lot of times when we think about low and middle income countries, we think more about infectious disease causes. But as these countries have had this transition to become more commercialized, as different things have come into place, factories, McDonald's, not to just call it McDonald's, but as you know, diets have changed and things like that, non-communicable diseases have become more of a problem. And so this was the first time really showing how much of a burden adolescent and adult cancers are compared to other things impacting this age group globally. And I think it was a surprise to a lot of people because even when we look at the lowest, the countries with most limited resources and low income countries, it's still one of the top 10 leading causes of death. And as you can imagine, this, just like in the US, these populations in some of these countries they are one of the more predominant age groups and really an important part of the workforce and economy. So an important age group to look at. And for the first time, the Lancet Oncology commissioned a group on AY cancer, and I've been fortunate enough to be asked to co-lead the epidemiology part of this commission. And so in the next couple of years, please look out for our commission report on AY cancer and really talking about this problem in this unique group of patients globally. And so for the research that I've done, for the first, just to set the stage, for the first time in 2017, the World Health Assembly specifically highlighted adolescents with cancer as an area needing focus. And Latin America is the area that I decided to focus on first in my research. It's a region that's made major strides in development, healthcare, and cancer control programs, but a large gap in knowledge remains of who treats AY patients with cancer and where are they treated. And you can see that these themes are kind of running throughout. These were things that we didn't know here in the US until not too long ago, and are also questions that need to be answered more globally. And so my project in Latin America, we named it basically Project Latin America AYA, which if you speak Spanish looks similar to playa, which is the beach. So in talking to my colleagues in Latin America, they liked that it had a nice feeling connotation. And I always have to give credit for this idea, for this collaboration to my aunt. She was diagnosed with ovarian cancer when I was in training and was treated at the Cancer Institute in Mexico City. And when I was going to visit her, she knew that I had an interest in adolescents, young adults, and that was the work I was doing in fellowship in the US, but then asked me, up to what age do we treat patients here in the US? Because in Mexico, in the Cancer Institute, in the general hospitals, they treat up to 15 in pediatrics. And then as a 16-year-old, you go to the adult side, and things change a lot. Visiting hours are very strict. Your parents aren't always able to go with you. And you can imagine for a 16, 17-year-old, even this 18-year-old, this could be very traumatic. And so she brought this to my attention, and I didn't know this before. And so then started to talk to colleagues in Latin America to see if they had any interest in looking at this age group. And so then this study was born. And so our objectives originally were to characterize oncology physician workforce and cancer centers potentially available to treat AYAs with cancer, to understand the barriers and facilitators to improving care for these patients. And like any good fellow, I started with a survey and then moved to interviews and focus groups, which gave us a lot more information. And so these are the countries that have been involved so far. We've actually also added Nicaragua and Uruguay and Ecuador. So I need to update this. But we have had a really robust response and people being very interested. And I say this to the trainees that are potentially on the call. When I first started this during fellowship about 8 years ago, I was told that there was too many other problems in these settings, that people weren't going to be interested in AYA oncology, that I'd have to wait 10 years to be able to do anything there. So I should really focus on my US centric work. And while I did heed that and continued to work here in the US and in California with my research, I also worked on creating collaborations with colleagues there for when the time came that people were ready and willing and wanting to focus on that group. And I will say it came much faster than anybody thought. So with our survey results, we say, we asked what the maximum aging years of patients treated with cancer at the institution, and the majority treated up to age 18. And I will say the majority of our respondents were pediatric oncologists, so keep that in mind. So this part of the survey was focused on pediatric oncologists. And then we wanted to know what dictates this maximum age. Is this provider dependent? Is it the government? And so we found most of it is hospital policy. And then we also found the second most common reason was the government. And then with interviews, we have now conducted about 70 interviews with different providers. We started with a pediatric and adult oncologist, at least one per country, which I know doesn't sound very much, but in some countries such as Haiti, was only one pediatric oncologist and one adult oncologist at the time, and there's not many more now. But so we tried to make it match kind of the human resources and the location. So here's an example quote. In hospitals, there isn't someone who the AYAs can turn to in order to have support, so they're alone. That makes patients not go to clinic or take their medications. And this we have seen makes them have more relapses, even though as doctors, we give them the right treatment. So when we're thinking also about best practices in delivery of care, even if we prescribe the correct treatment, there's so many other things that these patients face in getting that care that makes it really difficult for them. And a lot of these same barriers we see within the US, I think one of the ones that is different is abandonment of therapy, which means that they don't come back to complete their therapy. And I have had patients where that has occurred here, but it used to be a much more common phenomenon in low and middle income countries, of which they have made major strides, but not so much something we see here. And then we ask them for strategies to improve care for these patients. And this quote says, I think there's a special population that is vulnerable. We have to work as a team, not just a pediatric or adult oncologist, but there has to be communication between both parts, work with a multidisciplinary team. And you can see here in these strategies, this is a lot of the same things that are coming up within our interviews within the US too. One of the things people brought up was an awareness campaign. They felt like there's just really not a lot of awareness around this age group. And I think we have a bit more awareness here in the US just because this idea has been around a bit longer. And then a lot of discussion around financial support and job assistance after, and also standardizing treatment protocols. They felt there's not as much standardization there. So then we did a modified Delphi. For those that don't know what this is a consensus building a research strategy. And so we made it very broad and disease or cancer diagnosis agnostic. And we just wanted to get more an idea of what people thought should happen for this age group. And this also came out of my colleagues in Latin America asking for a sort of almost like a white paper or a paper that something that they could show their ministries of health, their hospital administration, their department chairs of why this group is important, and that these experts have all come together to say what is important about treating this age group. And so we had 18 proposed statements that we got from literature review, but mostly from interviews and our survey results. We had an expert panel that we put together that was 25 experts from 15 countries, 12 from Latin America. 12 of the countries from Latin America, 20 of the experts were from Latin America. And then consensus was defined as having a median score of 7 or higher on a Likert scale of 1 to 9. And so at the end, we had 21 endorsed statements. And so the majority of the statements were around clinical care. We then had supportive care services, education for physicians, and advocacy. So we found that I won't read you all of these, but just for example, in clinical care, if an AYA patient, which we defined as 15 to 29 to be more in line with what they thought the AYA age range should be, is treated as an adult institution or by an adult oncologist or hematologist provider for a cancer diagnosis that is more common in children than adults, a pediatric oncologist or hematologist should be consulted to establish a treatment plan. I know that's a mouthful, but basically just saying that really, this should be collaborative, and even if a patient is 18 and therefore mandated to be seen by an adult oncologist, but has Ewing sarcoma, really a pediatric oncologist should be involved because the adult side is not as proficient in treating that, just based on the volume that they see. And so we are working on the manuscript for this and hope to have it out soon. So then we did focus groups with AY cancer survivors. This is one of the things I'm actually the most proud of that we have done, and that I think has been the most useful in really directing how we can improve care for this patient population. So we did this during COVID, and so there were 7 focus groups, 24 participants. It was performed over Zoom. We had 7 countries participate: Peru, Mexico, the Dominican Republic, Guatemala, Costa Rica, Honduras, and El Salvador. This was run by a sociologist, originally from El Salvador, and she ran these focus groups. We did not make them country specific, so they were all mixed. And 5 main recommendations came out of the focus group from these survivors of AY cancer. They thought that all providers should be trained in how to communicate with AY patients with cancer. Communication about treatment plans should be ongoing, not just a one-time event at diagnosis. Emotional and psychological support should be provided consistently and regularly after treatment. And during and after treatment, information about long-term effects should be disclosed to patients, and support groups with other survivors of AY cancer should be available to patients during treatment. And so I think this is really important to give these patients a voice in how we improve their care moving forward. And this manuscript was written and the research was carried out by one of my trainees, Samantha Wong, who's now in internal medicine at the University of Washington and wants to be an oncologist. So I'm happy about that. And it just got accepted to the JCO Journal for Global Oncology. So hopefully you'll see that out soon. And so to date, I know there's a lot I've gone over, but we found that age limits, restricted exposure, and limited availability of AYA-specific services are barriers to comprehensive care of AYA patients. addressing this challenge, I think, really requires a health systems level approach, since a lot of what we're seeing are barriers around age cutoffs at which patients can be seen. And while just the age cutoff in of itself may not seem like, or may not seem like it presents a huge issue, um, there are lots of stories that I've been told around patients maybe being 17 and presenting to a pediatric hospital that only treats 16 and below, and then being sent to an adult hospital and then maybe getting bounced around and then having delays in care 3-4 months. And unfortunately, those types of stories are not uncommon. And so, how do we use this information to create change for this patient population? So, I do spend a large amount of my research describing the problem, but I am trying to focus more now on how to actually create change for individual patients and at the population level. And so, one of the things we did, and all the work that I do within Latin America, I really try to have come from the providers of what they want to do and have seen done. And so one of the things that they have asked is they really want to develop AYA specific programs. And so we got a grant from ASCO. I got 2 different grants, a Young Investigator and a Career Development Award. So it was really nice to see ASCO funding this work. And so one of the things we did with the with AMOP, which is the Mexican Society for Hematology Oncology, and then SLAUP, which is the Latin American Society, and then ALFCA, which is the Central American Society for Hematology Oncology, is we did a workshop where we put together all the different components of an AYA program that we saw in the literature from high income countries, things that they have said that they wanted within the interviews and surveys. And then you can see very technologically complicated. We used Post-it notes. And then we made these tables where they put the Post-it notes, things were listed on the left of importance. So high importance, less important, and then not important. And then factible is feasible, so feasible or not feasible. And so you can see that they saw many things were very important, but also found a lot of things to not be feasible. And we did this workshop in various countries and then also with these societies. And we also got invited to Paraguay to an adult oncology society to perform this workshop, which was very exciting to see medical oncologists also interested in this. And so then out of this, we just completed a modified Delphi. We did the survey with 52 potential components that came out of these workshops. It was sent via email. We sent to a little less than 200 providers, social workers, nutritionists, survivors of cancer, foundation leaders. Foundations are a huge part of the care that's delivered in Latin America, and we had about a 50% response rate. And it was a very long survey, so I was very pleased that this many people felt it was important to work on. And so we had everything done with a Likert scale, 1 to 9, how important it was. We also asked how feasible they thought it would be to implement. And then we also asked if they thought what the component was specific to an AYA program, or if they thought it was just important for general oncology care, so that we could really focus on what's important for an AYA program. And then some examples of components that were access to fertility preservation, multidisciplinary AYA tumor board, which is something that I wanted to give a shout out to my colleagues in Latin America who have actually put together a Latin American tumor board that meets once a month. It is run by SUBOPE, which is the Brazilian oncology group, and then SLAUP, which is the Latin American one, and then also the group out of Argentina. And it is specific to AYA cancer. And then this is, I think, an example of one of the biggest things that has come out of this work. So in the Dominican Republic, Dr. Wendy Gomez Garcia has been somebody that has been working with me since I was a second year fellow. And she messaged me to say that she was putting a proposal together to present to the First Lady of the Dominican Republic as they were building a new hospital, and wanted to propose that they increase the age of adolescents, young adults that they could treat from 18 to 24, and also was requesting AY specific services and an AYA unit in conjunction with one of the foundations there. So we put together a report based on all the work that we have done and the expert panels we have put together, and she was able to present this work to the Dominican Republic First Lady and was given the green light to go ahead with this, which I think is really incredible and a testament to my colleagues and everything that they have done to move this work forward. And then, sorry, this was a little grainy. One of the things that you saw that came out of this was wanting more education for providers in Latin America. And so there is a platform that I don't really expect anybody here to know about, but it's run by a foundation here called Elephants in Tea, and it's specific to adolescents and young adults, and it's a educational platform for providers of adolescents and young adults. And there's lectures on various topics such as fertility, disparities in care, and so all of these lectures, though, are in English, as would be expected. And so we have collaborated with them, and I brought to them the idea of, could we do something in Spanish using the platform that you already have? So there's a physician from Costa Rica who did some training in the US. And so she is now summarizing the different lectures and doing a 5-minute synopsis in Spanish that we've called AY Power in Espanol. And she's doing these synopsis. And then at the end, we're putting about 10 together to start as our pilot. And most oncologists in Latin America speak some English, so they can also watch the presentation in English, but we wanted at least a summary in Spanish to be able to help them make sure they understand the context. And then we will have a small quiz at the end, and then they can get a certificate that will be co-signed by Elephants in Tea and SLAUP, the Latin American Society, that will say that they have received this education in AY oncology, which our providers in Latin America have felt would be important to make this discipline feel more, be able to empower them to talk to their health administrators and health ministries as well. And so again, in all of that I do, I bring this back to, I mean, where you're born in the world is so random. And I just think that it shouldn't dictate whether or not you live or die from cancer. And so I really just always come back to this idea of really wanting to get patients the best care that we can, no matter where they live in the world. And so it takes a whole lot of people, as you can see here, and support. And I've been so fortunate to be surrounded by such amazing mentors, research analysts, coordinators, and trainees. So thank you. Any questions?
That was so great, Elysia. Thank you for giving us a whirlwind tour, of so many important issues. I have a question, but I'm gonna pause and see if anybody wants to raise their hand or to enter a question in the chat. Please do. We have a good 15 minutes. You did a great job ending with enough time. I had a question to get us started, but please do think of other questions. This is your time to speak up. I have a question about how many levels of influence that you're working across, and just it's just an amazing work working at the patient level, at the clinician level, the system level, and sort of like a national health policy level in terms of changing age requirements or coverage rates and things like that. I feel like what I heard you talk through is using your own clinical perspective as a lens into all of those levels of influence and trying to use the clinician voice, as a lever point. But could you talk about building a research program that is trying to do so much across all the levels or other pearls that you might have for others who have that same inclination? I want to work big. How do I build my work to do that? I think that would help people think about how you conceptualize it and how you think about it.
Well, I'll admit I never ever set out to be a researcher or to research big or work big. Um, a lot of it has just come into, I've been fortunate to be in the right place at the right time, but I will say that I I think a lot of it changed for me when I got my MPH between third and fourth year of medical school because everything was big. Everything was at the national level or global level, population level. And then working with Teresa Keegan and Ted One, just everything we looked at was at the population level. So I think I have a different lens from a lot of pediatric oncologists um, in that respect. And then some people think I'm too broad in the work that I do, so I don't know that I'm the best example for trainees. Um, but I do think everything is focused in that it is under the purview of adolescent and young adult oncology and improving care delivery. Um, but I do spend a lot of time mapping things out and seeing where they fit and if they make sense. And especially the work in Latin America. I know it sounds massive, but I think what's happened is there's just not that many oncologists compared to the US. So you have to work across countries, and a lot of these people work within the health ministries. And so that's kind of how it has occurred that way. Um, I don't know. I guess it's not something I really set out to do, but I always come back to is what I'm doing fit within this space.
Mhm. I like that. You have like a mission and you think about where you're trying to head and how to map it, the other thing I heard in your answer was it's all about people. You got exposed to different people in public health. You got exposed to different research groups with other types of researchers and other people in other countries, and you followed those threads and allowed it to, which I think is a really important lesson. So that was great.
Yeah, thank you.
Um, I see Patrick with his hand raised. Patrick, what question do you have?
Yeah, hi, it's Patrick. Yeah, this
Hi.
is fantastic work. I mean, it's just so amazing to see how your work has progressed over the last 5 or 6 years. Just awesome. And to see the impact that you're having, not just locally and nationally, but internationally. My question is about this is just an exceptionally challenging time to do global health work, isn't it? And you mentioned the World Health Assembly, and now, as of last week, the United States no longer participates in the World Health Assembly. And obviously, we've cut off the USAID grants that supported some of the international collaborations or could support some of the international collaborations that you described. So, how do you see funding opportunities in this field going forward? I'm sure you've been looking around and really trying to understand, where the money might be hidden under a rock, so to speak. But what do you think the future is for this kind of collaborative global health research?
Yeah, that is a good question and one I've been meeting with people to try to answer. Um, there does still seem to be some interest from, I think foundations is the main place, but everybody, as you can imagine, is applying to foundations right now. And so in that, I don't necessarily think that global health is at the forefront of what they would fund, but it still fits within what they say they will fund, a lot of them. The other thing is looking at the NCI, it's still possible, but you cannot have any money leave the US. And so that becomes more problematic though I do have colleagues that have R01s and things where they are doing work with our groups in Latin America and just all the money stays here. I have a little bit of an issue with that in that I feel like if you're doing work in these places that, they should get some sort of reimbursement or funding for what it is that you're doing. But it is something I've been looking at. I'm fortunate with my K to have my time protected, and the type of work I'm currently doing doesn't require a lot of money in that a lot of my collaborators they're happy to do the work and participate and be involved without any sort of reimbursement. And I'm lucky to have slush funds that I have not had to touch. That now that my ASCO grant is ending, we'll probably need to dip into, but to be honest, I will continue this work and we'll try to do it with as little money as possible, but also looking into applying for the NCI grants and things and just trying to figure out how to keep all the money here. I know it's not a fabulous answer, but even like St. Jude, which I collaborate with a lot because they don't have anybody doing AYA work. They've always had a lot of money and have now even had cuts and have been reining back their funding as well. So I think everybody's feeling it and everybody's trying to figure out how to move forward with it. I have also been asked to co-chair a global oncology initiative for the Cancer Center. And I'm very grateful that the Cancer Center and Dr. Laura are still supportive of this initiative given the current climate. But we are working together to see what kind of funding mechanisms we could apply to, and perhaps as a larger group with people that have been very successful in the past, such as Luis Carvajal Carmona, Laura Fejerman. But yeah, I don't know what the future will hold, but I need this work to keep going one way or another. And so we will figure it out.
I love that that answer is also about partnerships and people too. A great theme of your work, Elysia. We have time for one more question. I want to pause before I ask. Any final questions from the group? I was just curious about implementation science. I know you say you're new to it, and I know you're using CFIR, which is like a framework. For anybody that's newer to it, like you, do you have any sort of lessons about how implementation science is going to fit into your research or what you've already learned from it that has been useful to you? That because you talked about it broadly, but like a little specific example for people here who know about it but haven't quite applied it to their work.
Yeah, so you probably are sensing a theme within my work too, that I'm really passionate about the global work. So I was looking for something that would a skill set to learn as I was applying for a K, that while I was not applying for a global project, that would also help me in my global work. And since a lot of what I do is around getting patients the most appropriate care, and while we do need better and different oncology treatment, cancer treatments than we have now, I have found in our work that we're not even getting patients the current best standard of care, which is not only a problem here in the US and in California, but also abroad. And so when I was looking around as to what skills I felt that I could learn to really further this work, implementation science was what I found. And while I'm still wrapping my head around it and have a wonderful mentor, Dr. Midbow, for me, I think it's a vehicle to take all these ideas that I think a lot of us have in how we could do this type of work, but really solidify it and make it protocolized and around a framework in a way that can be measured and in a way that you can measure success or not, and how to really go about it from the beginning with the actual like stakeholders and moving it all the way forward. Because I think a lot of times what we do, and I think a lot of times what people do, especially in global work, is take our ideas of what we think need to be done and put them upon people rather than starting from the beginning and seeing what may work in different spaces and what is coming from the people actually providing the care. And so I felt like science really fit within that goal of mine.
Another proselytizer for implementation science. I love it. We're going to
I
bring you
mean,
in.
I'm not there yet, but
You're on the way. I can already tell. Yeah, and then just for everybody in the room, what I heard from that answer was really about what we call in implementation science, the real evidence practice gap. Like what is the real gap that I'm trying to solve, and really paying attention to that and really being true to that, which it sounded like you almost pivoted a little bit in terms of you haven't, you're still going to work on the entire gap. But like when you think about evidence to practice gap and you think about people just missing that evidence completely, right? Then what are the methods that I need to go after that kind of gap, right? That's a different question. It requires different people to answer those questions. And so again, I just love that you've listened to where the science is sending you. And I think that's a really important lesson for everybody on the call to hear, because that's what gets us rigorous and great studies, is people who are really thinking about it at that macro level. Well, this was amazing talk. I'd love to see the progression
yeah.
of your work too. So thank you so much for joining us today. Um, a lot of thanks and congrats in the chat for you, Elysia. And you're here at Davis, so if people want to reach out to you and hear more about
Yeah,
your work,
please
I'm
feel
sure,
free.
yeah, they can email you. But I really appreciate it, and I hope everybody has a great day. Thank
Thank
you.
you so much.